Hello friends, let us now learn some important points about the neck injuries. Neck injuries are these injuries are actually penetrating injuries because they penetrate the platysma. These are seen deep to the platysma. Major vascular structure and aerodigestive structures are present in the anterior triangle deep to the platysma. So in the neck injuries, two anatomical structures are very important. One, it is platysma, second sternocleidomastoid. So we can divide the injuries based on platysma as those injuries which are superior to platysma are called as superficial injuries, and those injuries deep to the platysma are called as deep injuries. These deep injuries always need evaluation. Then based on sternocleidomastoid, again we can divide the injuries into two types. One, injuries anterior to sternocleidomastoid, we divide it as significant injuries, and injuries are divided as posterior to sternocleidomastoid. These injuries which are posterior to sternocleidomastoid has less chances of developing major vascular injury. So, whenever there is a penetrating injury in the posterior to sternocleidomastoid, then this can cause injury to cervical spine and spinal cord. So, now important points is about the zones of neck injury. So, we can divide the zones in the neck into three zones. So, if this is the person, now we have divided it into three parts. Okay, the first, this is the sternal notch, that is the cricoid cartilage, and this third is angle of mandible. So the area between the sternal notch and cricoid cartilage, we have zone 1. The area between the cricoid cartilage and the angle of mandible, this is zone 2, and above the angle of mandible, this is zone 3. So this is zone 1, zone 2 and zone 3. Now zone 1 is present between the sternal notch and the cricoid cartilage. This zone 1 structures located are carotid vessels and aerodigestive structures. Then zone 2 is present between the cricoid cartilage to the angle of mandible. Then this zone 2 is the most exposed area. As a result, it is most injured zone and it is most surgically acceptable zone. So it has best prognosis. In zone 3, it is between the angle of mandible and base of the skull. So it is difficult to operate. Signs are important. The signs in neck injury can be divided into two types. One, we have hard signs and soft signs. Hard signs are life-threatening signs like pulsatile flow of blood from the wound which is expanding, or pulsatile hematoma, or air gushing out of the wound can be there. So these are hard signs. We have soft signs. Soft signs is previous history of bleeding, hematoma, hoarseness of voice will be the soft signs. Treatment depends upon these signs. So first, stability. If the patient, one first criteria is hemodynamic stability. First, if the patient is hemodynamically unstable, then the hard signs, you will have to look for hard signs. So hard signs like uncontrolled hemorrhage, massive hemoptysis, expanding hematoma and shock are mostly present. In such cases, we will have to do operative management. Then if the patient is hemodynamically stable, then mostly soft signs will be seen. Soft signs like dysphagia, venous bleeding, subcutaneous emphysema or hematoma, or presence of hoarseness of voice, stridor and odynophagia. These will be present. If there is hemodynamically stable, now you should do based on the zone. If the patient is in zone, if the injury is in zone 1, then we should do CT angiography plus esophagogram and bronchoscopy is done. So we will do CT angiography is done to see whether the to see whether the vessels are fine or not, then you should do esophagogram and bronchoscopy to view or to look at the esophagus and bronchial injuries. If there are any injuries, then we go to operative exploration. Then in zone 2 we should do CT angiography for neck and chest, because here the major vessels are seen in zone 2. So here if it is positive, then we have to go to operative exploration. Then in zone 3 we have to do CT angiography and neck chest again, and here if it is positive, then because operative exploration is very difficult in zone 3, we do angioembolization is preferred in zone 3. Next, if he is hemodynamically stable and asymptomatic, then if it is zone 1, then you should always rule out any injuries. So you do angiography, CT angiography, esophagogram and bronchoscopy is done. And now if he is of zone 3, then you will have to observe the patient. If he is of zone 2, then and gunshot wound, then definitely you should do CT angiography, esophagogram and bronchoscopy, because there is a chance that the gun has entered to any of these structures. But if the zone 2 injuries are not gunshot and they are others, then we should just observe the patient. So these are the important flowchart for neck injuries. Right now, zone 3 is very difficult to operate, and among all these, the best prognosis is present in zone 2. So this is about the neck injuries. Now let us learn about the rib fractures. So rib fractures, these occurs mainly secondary to compression of the ribs. It can be anteroposterior or lateral compression. Clinical features include pain. On examination, you see presence of crepitation and subcutaneous emphysema is seen. So in rib fractures, you will see mostly fractures of typical ribs. Atypical ribs like first rib, 10th to 12th rib fractures are uncommon. Only very high velocity impact can cause these fractures. Then first rib if there is first rib fracture, always suspect the injury to subclavian vein, brachial plexus and apex of the lung, because these are in close proximity to the first rib. Then if there is fracture to the 10th, 11th and 12th ribs fracture, always suspect the injury to liver and spleen, liver on the right side and spleen on the left side, because these 10th, 11th and 12th rib will cover the liver and spleen. Both these will cause hemoperitoneum. Then diagnosis is, we can do chest x-ray can be done for diagnosis. Chest x-ray is done for diagnosis, and treatment of choice is conservative treatment is done with adequate analgesia, and strapping should not be done. In olden days, whenever there is rib fracture, strapping used to be done, but now we do not do any type of strapping. Then most common fractures of ribs which you see during CPR is 4th to 6th ribs. So this is about rib fracture. Thank you for watching.